Hello everyone, my name is Kassidy Singh and this is my presentation on my Doctor of Nursing Practice or DNP Scholarly Project entitled Addressing Post-Traumatic Stress Disorder and Substance Use Disorder Treatments. And let's get started with our introduction. A little bit about my background. I am a psychiatric mental health nurse practitioner and I have been working in substance use disorder treatment for a little over 13 years now. And in that time, I have recognized various gaps in care, with one of the more prevalent gaps in care that I recognize being the neglect of comorbid trauma and post-traumatic stress disorder. So when selecting a topic for my DNP Scholarly Project, I wanted to begin a process of integrating trauma-focused interventions and the principles of trauma-informed care into the standards of substance use disorder treatment. As I mentioned, this is going to be a presentation on my DNP Scholarly Project, which focuses on addressing comorbid post-traumatic stress disorder, or PTSD, and substance use disorder, SUD treatment. The interventions on my project involve PTSD screening, PTSD education, and psychiatric referral. The setting for my DNP Scholarly Project was an inner-city inpatient SUD treatment facility, and my project was implemented within the facility's inpatient detox and inpatient residential programs. Topics of my presentation will include background, purpose and aims, methods, results, discussion, and implications. Let's move on to background. So my DNP Scholarly Project focuses on the comorbidity or co-occurrence of two psychiatric disorders. The first being substance use disorder and the second being post-traumatic stress disorder. So what is post-traumatic stress disorder? PTSD is a psychiatric disorder that sometimes develops following exposure to traumatic events or trauma. Trauma meaning events that are deeply emotionally or psychologically disturbing, such as physical abuse or sexual assault. PTSD has certain symptoms associated with it, including reliving or intrusive symptoms such as nightmares and flashbacks, and other symptoms including hyperarousal, avoidant behavior, negative emotions, and sleep disturbance. The second disorder that my DNP project focuses on is SUD. SUD is a psychiatric condition in which individuals continue to use substances despite knowing the harmful consequences associated with that substance use. So why focus on PTSD and SUD comorbidity? Well, we know that the relationship between trauma and substance use is bidirectional and cyclical, with trauma often leading to substance use and substance use often leading to trauma exposure. For example, individuals who have been exposed to trauma often use substances to cope with the negative feelings and emotions associated with that trauma exposure. We refer to this as self-medicating. Additionally, individuals with SUD are often placed in high trauma-prone environments, making them at higher risk of being exposed to trauma. So this is what I mean when I say that the relationship between trauma and substance use is bidirectional and cyclical. Research has long recognized the prevalence of PTSD amongst the SUD population. Actually, research notes that there is a 30 to 58% prevalence rate of PTSD amongst the SUD population. Extensive evidence supports the integration of trauma-informed care, or TIC, into SUD treatment due to the long recognized prevalence of trauma amongst the SUD population. Additionally, research tells us that addressing PTSD and SUD treatment is critical because unaddressed and untreated comorbid PTSD makes establishing recovery from substance use challenging, if not impossible. Furthermore, PTSD and SUD comorbidity often results in worse symptom severity, treatment outcome, and overall poorer prognosis, making addressing PTSD and SUD treatments of high priority. Let's move on to the next topic, which is purpose and aims. What did I hope to accomplish with my DNP Scholarly Project? The purpose of my DNP Scholarly Project was to integrate the principles of TIC into SUD treatment. Now you may be asking, what is TIC, or trauma-informed care? Trauma-informed care is a theoretical framework that recognizes the impact that trauma can have on a patient's well-being. TRC comes with various practice guidelines to guide treatment providers to treat individuals who have survived trauma. For example, some TIC practice guidelines involve universal trauma screening and also PTSD screening. My DNP Scholarly project was a quality improvement project, and the overall purpose of my project was to identify adult individuals who have a SUD and potential PTSD. The primary intervention of my project was PTSD screening, and this was done via the primary care PTSD screen for DSM-5 or PCPTSD-5 screening tool, which is an evidence-based screening tool that screens for PTSD. It was designed to be used in the primary care setting, but it can also be applied to the inpatient setting. The secondary interventions of my project involve PTSD education and psychiatric referral. This was important to note that it was not just enough to screen for PTSD, but it was also critical to provide the education of what the disorder is and the available treatment options. Also, referring the patients to psychiatric services was critical to begin the process of diagnostic evaluation and potential treatment for comorbid PTSD. My project hypothesized that through incorporating the principles of TIC into SUD treatment, there would be an increase in PTSD screening, PTSD education, and psychiatric referrals. So let's move on to methods. My DNP Scholarly project was a quantitative, exploratory design through a retrospective chart review, which basically means that I reviewed EMRs or electronic medical records for individuals who were admitted to the SUD treatment facility. I grouped participants into two groups, the pre-intervention group and the post-intervention group. The pre-intervention group consisted of individuals who were admitted 6 months prior to the implementation of my project, and the post-intervention group consisted of individuals who were admitted 10 weeks after the implementation of my project. Participants in both groups were males and females between the ages of 18 to 89 who were voluntarily admitted to the inpatient SUD treatment programs, detox and residential programs, and who also reported a positive trauma history upon admission during the standard pre-admission intake form screening. Individuals in the post-intervention group received PTSD screening via the PCPTSD-5, and these individuals who screened positive on the PCPTSD-5 received PTSD education, which was either verbal or written, which consisted of a facility-approved handout on PTSD from the SUD intake clinician. Participants who screened positive were also referred to psychiatric services by the SUD intake clinician for diagnostic evaluation and potential treatment for PTSD, as I mentioned earlier. It's important to note that the interventions of my DNP Scholarly project, all three of them, PTSD screening, PTSD education, and psychiatric referral, were completed at the discretion of the admitting SUD clinician and with the consent of the patient. I did not engage any participants. Let's move on to our next topic, which is actually showing what the PCPTSD-5 looks like. So as we see here, this is a PCPTSD-5 screening tool. A very straightforward screening tool, again, evidence-based, free to public domain. It starts off by screening for trauma history, individuals who have survived trauma, such as, again, physical, sexual assault, war, secondary trauma, would answer yes, and then they would proceed to these sequential 5 yes or no questions. A positive screening is considered answering yes to 3 or 4 of the 5 questions. And again, individuals who screen positive receive PTSD education and were referred for psychiatric services. So let's move on to results, and let's go by intervention to intervention. Let's start with our first intervention, which was PTSD screenings. So, what happened with the PTSD screenings? There was about a 32% increase in the number of PTSD screenings conducted from pre-intervention to post-intervention from my DMP Scholarly project. This is a very important finding because it indicates that the research that notes that there is a high prevalence of PTSD amongst the SUD population is in fact valid, and this is evidenced by this finding. And amongst these individuals who received the screening, about 53% screened positive. This is also important to note because before the implementation of my project, these individuals would not have been screened at all, and they would potentially not have received the subsequent interventions of my project and have received direction of being referred to psychiatric services for treatment. Let's move on to the next intervention, which was PTSD education. And my project found that there was about a 17% increase in the amount of PTSD education provided from pre-intervention to post-intervention. This is very powerful finding. Again, it wasn't enough to just screen individuals for PTSD. I really wanted to provide the education on the disorder and provide individuals who screen positive with the knowledge of what their available treatment options were. This finding also indicates that, there was a decrease in the stigmatization of PTSD. Individuals who have survived trauma have a lot of shame surrounding their trauma and often don't discuss it. So what this intervention did was not only provide education, but begin a process of destigmatizing the stigma associated with PTSD. The next intervention of psychiatric referrals, there was actually about an 11% decrease in psychiatric referrals conducted from pre-intervention to post-intervention. And I'll detail the reasoning behind this because, again, I did hypothesize that there would be an increase, obviously, in psychiatric referrals with the increase in screening and education. And I will discuss that in the discussion section, which is now. So, discussion. The increase in PTSD screening supports the need for this valuable intervention in SUD treatment. Again, what the result of my DMP Scholarly project indicates is that there were individuals who were entering treatment for SUD who had underlying comorbid PTSD, and it went unassessed and possibly untreated. And again, this is detrimental to the patient's overall treatment and prognosis because unaddressed and untreated comorbid PTSD makes establishing recovery from substances challenging, if not impossible. The increase in PTSD education indicates that as a result of this project, there was an increase in patient understanding of the disorder of PTSD. Again, individuals who have PTSD are often unaware that they have the disorder, and they're often unaware of what the disorder is. So it wasn't enough to just screen for the PTSD. It was critical to provide this valuable education. Studies have estimated that 89 to 97.4% of individuals with SUD seeking treatment have a positive trauma history, and 30 to 60% of these individuals have undiagnosed PTSD. So we can't rely simply on the patient to come in and say, hey, I have PTSD. We have to universally screen these individuals with positive trauma history for PTSD and give them the tools and resources to know what PTSD is and know what their treatment options are. For the last intervention of psychiatric referral, as I mentioned earlier, there was a decrease from pre-intervention to post-intervention. And I conclude that this was due to improvements in clinician assessment due to the PTSD screening. There was a elimination or a reduction in unnecessary psychiatric referrals. The results of my project support incorporating PTSD education, screening, and psychiatric referral amongst all individuals with a positive trauma history into the standards of SUD treatment. And it's important to note that I said positive trauma history. Individuals who do not have a trauma history obviously do not need to be screened for PTSD, but individuals who do have a positive trauma history need to be screened for the disorder that is most prevalent with trauma exposure, which is PTSD. Meaning it's not enough to just screen for a trauma history and not screen for PTSD, because really, what is the point of just screening for trauma and not screening for the disorder, again, that is perhaps most commonly associated with trauma, PTSD? And let's move on to the next topic, which is implications. Implications for nursing practice. Implications for practice from the results of my project indicate that SUD treatment providers, such as myself, as psychiatric mental health nurse practitioners, should provide routine trauma-focused interventions, including PTSD screening, when treating a SUD patient who reports a positive trauma history. Meaning, as treatment providers, as SUD treatment providers in particular, when we screen for trauma history, we need to be screening for the symptoms associated with PTSD as well. This is a holistic and complete assessment of the patient's needs. Moving on to implications for healthcare policy. What my DNP Scholarly Project implicates for healthcare policy is that there should be universal PTSD screening on individuals with a positive trauma history. Meaning there needs to be policy change saying that, again, if an individual has a positive trauma history, we need to be screening for PTSD. And quality and safety. What does my DNP Scholarly Project implicate for quality and safety? Integrating trauma-focused interventions into SUD treatment is safe and yields an overall higher quality of care. PTSD screening is safe and it yields a higher quality of care. Again, no participants, to my knowledge, were negatively impacted by the project's interventions. No one received a lower quality of care. I know there is often concern of re-traumatization, relapse in substance use, and poor treatment outcomes associated with screening for PTSD amongst SUD treatment providers. But we know that these concerns have been dismissed by the research, because the research tells us that screening for PTSD and SUD treatment results in a overall better quality of care for our patients. The concerns of re-traumatization are just not valid or warranted in SUD treatment that screens for PTSD. Future research. What do the results of my project implicate for future research? Well, further research is needed into the prevalence of trauma and the impact of trauma-focused interventions in SUD treatment. Again, trauma, substance use go hand in hand. We need to be doing more research into how we can address this need into the SUD population, into the SUD treatment that we provide. Additionally, I recognize that trauma is not the only neglected need amongst this population. More research is needed into other areas of care that we neglect, such as medical needs, including pain, psychosocial components of the disease, including poverty. And let's move on to our conclusion. This was a presentation again on my DNP Scholarly project, which focused on addressing comorbid PTSD and SUD treatment. My interventions on my project were PTSD screening, PTSD education, and psychiatric referral. Topics of my presentation included background, purpose and aims, methods, results, discussion, and implications. Here are my references. Please pause if you need to. And any questions, please feel free to email me at casing4@live.maryville.edu. In conclusion, I would just like to say that I'm so proud of my DNP Scholarly project, and I'm so proud to contribute to improving the quality of care for the SUD population, which is a very vulnerable population to treat, very complicated population to treat. SUD is such a complicated and complex disorder, and there's so many etiological factors that go into treating SUD, with trauma being one of them. We have to be screening for PTSD amongst individuals who report that they have a positive trauma history. We need to give the education on what the disorder is. Again, we can't depend on the patient to come in knowing what their needs are. We have to assess them for and recognize their needs and educate them on what we think their treatment needs to focus on, and give them the tools and the power to ask for help and know what they need help with. I thank you so much for your time and consideration in watching my presentation. I hope this was insightful and informative. Again, if you have any questions, please feel free to reach out. Thank you very much.